Hello, everyone. Thank you for taking out your valuable time on Saturday to be here with us. So, at Stepping Stone Center, we felt the need to go beyond just providing therapy services to our children. Hence, we restarted our monthly parent support group to support our parents as well, just as we had attempted to do before COVID struck. This is an important part of providing a holistic service approach to our children as they do not exist in isolation. As our recent research, which a lot of you were part of, proved that even though our kids may steadily show improvement, the parents' level of stress may not reduce in the same rate or pattern. As a parent myself, I can relate to how one thing after another impacts our stress levels. So, we have taken this initiative to provide you all a place to get together, share experiences, bond, engage in stress busting and mental health strengthening activities together with us. So, a little bit of fun and a lot of learning will happen together. Before we start the session, we are excited to share that our parent support group sessions are now streamed live on our YouTube channel, making it easier for everyone to stay informed and engaged. If you missed the last session or know someone who couldn't attend, you can catch up anytime by subscribing to our channel and accessing the recorded sessions. So let's start today's session with a small game. This is going to orient you towards today's topic. Okay? Whoever is present in the Zoom meeting today. We're going to show you some words that are scrambled, unscramble them quickly, and type the word out in the chat box. Let's go. Sujata, will you be able to see the chat box? Because I can't access anything here. Mhm. Mm. Okay, I think we are going to come back to this game then. All right. So, to start with the session, navigating the maze of autism can feel very overwhelming, both for individuals with autism and their loved ones. It's a journey of understanding unique strengths, overcoming challenges, and embracing neurodiversity. The key to finding your way forward lies in fostering acceptance, building supportive environments, and advocating for personalized approaches that empower individuals to thrive. A developmental pediatrician plays a crucial role in this path, offering expert guidance to assess developmental milestones, diagnose concerns early, and create tailored intervention plans. With their support, families can better understand the unique strengths and needs of an individual with autism. Through early diagnosis, therapeutic strategies, and coordination with other specialists, these medical professionals help pave the way for growth, inclusion, and improved quality of life. Together with the right support systems, we can transform the maze into a path of empowerment and meaningful connections. Today, we are honored to welcome Dr. Nelia as our esteemed guest and speaker. Dr. Nelia is a distinguished developmental pediatrician in the Unit of Hope Center for Children with Special Needs, based at St. John's Medical College Hospital in Bangalore. She earned her MD in pediatrics from CMC Ludhiana, where she graduated with a prestigious gold medal for securing the top rank. Additionally, she completed the IAP Fellowship in Neurodevelopmental Pediatrics at St. John's Medical College. With over a decade of excellence in pediatric care, Dr. Nelia has acquired invaluable experience working with diverse populations across rural and urban India. Her unwavering dedication to improving the lives of children with special needs has been a hallmark of her accomplished career. Dr. Nelia, we're really grateful and excited to have you here with us today. The floor is all
Hi,
yours.
thanks, Dr. Nelia. I work in St. John's at the Unit of Hope, which is a center for children with special needs. So I am very honored to be here today, and as part of the Autism Awareness Month, I think it's a great time to just connect with the rest of the community that we work with. Okay, so can I have my first slide? Right. So I wanted to start with talking about the medical and social model of disability. In healthcare, I think as doctors, we think that everything is needs to be fixed, and we work to fixing the person. But I think autism is not a disorder like that. Autism is not a disease. And so we look at the Unit of Hope, and how we work is that we see it more as a social model. If a child can't do something, it is because of the societal and environmental barriers. So we work at creating, and all of us together, I'm sure, as parents and therapists, we work at changing ourselves and changing our attitudes and barriers. We accommodate, we provide adaptations for these children so that they can be independent and functional, and therefore they will no longer be disabled. Next slide. So as we know, autism is a spectrum, and we have different levels of support, where one is the least support and three requires some more support from parents and caregivers and community. And this could be in different areas. So it's not that somebody would have that same level in all the domains. So you have verbal, nonverbal, social reciprocity, social relationships, RRBs, and intellectual ability. This could vary across the spectrum. So the spectrum is not just one linear spectrum. Within that, the child may have different strengths and different challenges, and we need to work with that. Next slide, please. So a lot of the times when we see a child in a family, and we have done the assessment, or before the assessment, we feel this child is on the spectrum. A lot of parents come referred because their teachers have referred them, the school has referred, the therapists have referred, and then we assess the child. And then the first thing they ask is, why did this happen? So science, literature, evidence has shown that approximately 80% is genetic. But genetic doesn't mean that they have inherited it from their parents. Okay? So there's a difference between genetic diseases and hereditary diseases. And so sometimes parents ask us that also. Like, no, but nobody in our family has had this. So how did this happen? So in autism, there are few genes that do cause autism, but most of it is multiple genes and multiple changes. So, but it is a change in the gene. Hereditary means it's something that is passed on from the parent to the child. For example, certain, maybe you would have heard of certain blood disorders like sickle cell anemia or thalassemia. So those are hereditary because the parents carry that gene, or Duchenne's muscular dystrophy. But genetic disorders don't all have to be hereditary, because maybe just that child has a particular change in the gene. But all hereditary diseases will be genetic, but not all genetic diseases are hereditary. Okay, so some cases we also ask for genetic test. Again, when we ask for that, it's just to know, to understand more about, not every ASD child requires a genetic evaluation. We may even get to, in my later slides, I'll explain which cases we do think of doing a genetics. but it is not ever to put the blame on either parent. Okay, it is just to understand the process a little better to see if there are any other comorbidities, which is another thing we'll be talking about, because ASD doesn't usually happen in isolation. So then it brings us to the question, so we have hereditary, we've got genetic. Now, what does congenital mean? So congenital means something that the child is born with that may neither be hereditary or genetic. For example, if you have a child with a hole in the heart, or a child with spina bifida, like a spinal tube defect. So those are congenital because the child has been born with it, but that may not be hereditary. Okay, it could be just some change that happened during embryology when the baby was being formed in the uterus. So, but some of these do have an overlap. Okay, so this was just to kind of give you an overview. What does hereditary mean? What does genetic mean? What does congenital mean? Okay, like for example, if you've heard of Down syndrome, that is a genetic disorder, but it's never passed on from the parent to the child. But then it's there since birth, so it will be genetic and congenital. Okay, but there's some disorders which are all three. For example, I was saying some of the blood disorders like sickle cell anemia. All right, so that was just a little bit about what what causes autism, though we still don't know. 80% is genetic. So now we've got a few risk factors. So some of the risk factors are antenatal. That means before the baby is born, while the baby is in utero. So this could be exposure to pesticides, pollution, if the mother had diabetes during pregnancy, if the baby was very preterm, if the baby was low birth weight, if the baby had some uh, during delivery, there were some complications and the baby didn't get enough oxygen to his brain, or he passed stools in utero. So that is what we call perinatal asphyxia, when the child did not get enough oxygen at birth and had to be kept in the NICU for a short while. Um, Evidence has also shown that increased paternal and maternal age independently. So parents above 40 years is a risk factor. Not again, these are just risk factors. This is not what causes autism, but this all these things together may increase the risk of the child having autism. Next, please. If the mother was on certain drugs during pregnancy, like valproate, sodium valproate is a drug for seizures. Fluoxetine is a drug for depression. Then next, yeah, and some syndromes, and like we talked about genetics, some changes in the chromosomes may also cause predisposed to autism. And then there's something called epigenetic. Maybe you've heard that word floating around. So epigenetic is the influence of the environment and the gene. Okay, if you could press enter again on the slide, yeah. So the gene may be a normal, a gene that is susceptible to injury. And then there was something in the environment that came, like pollution or pesticides or some toxin. And then the gene mutated and became an affected gene. So it's the interplay of the gene and the environment is what we call epigenetic. Okay, next slide. So autism is a neurodevelopmental disorder. When we say neurodevelopmental, it means it's in the brain. It's during the brain's, when the brain is being formed and the networks are being formed and the synapses are being formed, there are some changes. Okay, so we have seen that a lot of children with autism, their brains are a little bigger and their head sizes are a little bigger than the average child. Okay, so we have different reasons for that. Next slide, please. So if we look at this, this is what normal brain growth looks like. Okay, so synapse formation is where the nerves meet and then send the signals to the next nerve. Yeah, that's how the messages are all transmitted in our body. Like if we smell something, we first smell it, And then that goes to our brain, it goes to another signal in our brain, it goes to another signal in our brain, and then that processes the information. So at birth, there is less synapse formation. And as we all know, maximum brain growth happens in the first 2 years. So you see by 6 months and 1 year, how busy that is. There's so many networks being formed. But after that, there's something called pruning. Okay, like in a tree, we can't just have the tree grow crazy with lots of branches. Then you don't get good fruit. It's a waste of energy also. So in the same way, next slide, there's something called pruning where where the body, okay, due to autophagy, the body cuts off the parts that are not required. The improper synapses are removed. But what happens in autism is there's impaired autophagy. So the brain is not pruned as it should be. So there's a lot of extra information and sensory overload happening. Next slide. Yeah. So the first slide shows us a neurotypical cell. Okay, so the pruning has happened. So there are there are fewer synapses and dendrites, okay, that have been pruned. So then in the next slide, what is happening in the next picture, it is the neurons from an autistic child. And there are so many synapses and receptors that have not been pruned. Okay. So because of that, they are seeing the world in a different way. They are processing the world in a different way. And that's why there's so much sensory overload, because there's just so many signals coming into their brain. So the brain density and size is typically more in a child with autism. Next slide, please. So if you can see, that's a normal brain, okay? And the autistic brain is a little larger with way more connections. But the opposite can also happen. There are a lot of studies, they do this using functional MRI, where they found that sometimes there's hypoconnectivity also. Next slide. Next slide, please. Yeah. So there's hypoconnectivity, which means certain areas are not getting the signals, it's not being passed as it should be. So what I'm trying to say with all this is, autism is not a disease. It is just the way the brain is wired is different from maybe some of us. Okay. So if the brain is wired differently, the brain sees things differently and processes it differently and thinks differently and smells differently. And that is why they also are neurodiverse. Okay, next slide. Yeah, so this is a very, very simple slide. Okay, it is the brain is way too complex to just summarize like this, but there are different parts of the brain which control different functions. And when we have done the functional MRI, we have seen that there are actually functional differences in the brain. Like the frontal lobe is what shows the executive function. Okay. The temporal lobe is what causes differences in the way the temporal lobe is wired, is what causes a communication problem. The underdeveloped brainstem may be responsible for aggression and self-injurious behavior. The hippocampus and the amygdala, these affect memory and learning. And the basal ganglia, if there's dysfunction there, leads to the RRBs, the repetitive restrictive behaviors. However, again, this is very simplified. And the good news is, next slide, because the brain is so young and the brain is still developing, early intervention makes a huge difference. Okay, so it doesn't, if those brain structures can actually change. Okay, so this is a simple way to think of the brain. Most brains, if we imagine the brain like a map, okay, so our brain is like a map, and the pathways are like the roads, and the junctions are like the synapses. Most brains have the same kind of maps and the same kind of junctions. But what happens in an ASD brain? Can I have the next slide? I mean, the enter. Yeah, this is what an ASD brain looks like. There are just so many things going on. The roads may be wider, the roads may be narrower, they may be shortcuts, there may be traffic jams. Imagine the cars are what carry the signals, okay? There may be traffic jams. So there are just so many things happening. It's difficult to focus. All right, next slide. Next slide. Yeah, this is where I got this from. This is actually made by an autistic girl. She's now an adult and she's an illustrator. And maybe I could share this with you. It is how the autistic brain thinks. Okay, so it talks about how even autism, each autistic person is different from the next. Okay, so the differences are in our brains and how we think. Next. So it talks about exactly what I've just said now, how the signals are transferred. Next. Most brains have maps that look similar, with all roads being about the same size. Next. Like this one. Okay, very, very clear. Each pathway has a role. Each synapse has a function. Next. But autistic brains, each autistic brain has a different map. Okay, the roads are different. And this means we see, think, and feel things differently from most people and at different speeds. So it's not just processing it different, even the speed is different. So they may take longer to appreciate something. Doesn't mean that they are not appreciating it. Yeah, next. So this is from a girl who has autism. So this is a lived experience. So this is not like something I have done. This is actually what she feels, and she was able to put that onto paper. Next. Yeah. So this slide is a nice slide. Can you make it a little bigger? Or can I make it bigger? Can everyone see it? Yeah. So in the same autistic, like people with autism, depending on how their brain is wired, can have different needs and different traits. Okay, some of them love loud noise, some hate loud noise, some love to push and pull and climb. The others like to be very still. Okay, some need to jump, some need to be silent, don't talk much. Okay, so because of the way the brain is wired, no two autistic children will ever be the same. Okay, yeah, next. Next slide. Yeah, we can, yeah, so this is because our autistic brains process information differently. We need people to understand. We may be really quick to learn a new skill or take much longer. We may be very sensitive to some signals like loud noises or rough fabrics, because our signals can get a traffic jam if we take in too much information. And if there's too much traffic, we may not be able to do the things we can do when we are calm. And we need to do things differently because our brains work differently. Okay, next. So this is all just about the brain, because everything starts with the brain. So even our comorbidities it helps us to understand the other co-occurring problems in autism. Next. Okay, maybe we can come back to this because I think this is very special, because I think autism in girls is very different from autism in boys, and that's an area that needs to be explored, because autism in boys and girls, the ratio is 4:1. But we are seeing a lot of girls with autism, and maybe at the end of this week, if there are any parents with girls who have autism, it would be really nice to discuss that, because I think girls mask a lot more than boys. And when they do have autism, it is different dealing with them because their problems are different. So we'll come back to these slides. Can you move on? Yeah, next. Next. I'll come back to these. Next. Okay, so ASD and its co-occurring conditions. So it could be medical and it could be behavioral also. So medical, the seizures, the eating disorders which later lead to deficiencies, constipation, diarrhea. Sleep issues are huge. Dental issues are huge. They can have visual issues as well. They can have pain, which they're unable to articulate. Behavioral issues are anxiety, depression, OCD, ADHD, intellectual disability, and self-injurious behavior. We'll be talking about some. Next. Yeah. So autism, like I said, is never in isolation. The brain is a very complex organ, and it is connected and interconnected. So younger kids, it might be hard to pick up anxiety, but as I grow older, definitely anxiety is one issue. And this was a really interesting slide because anxiety affects their behavior. Okay, so what we see is a child not eating, a child crying, a child with a lot of anger, a child being clingy, a child being fidgety. This could all be because of anxiety. So I think as parents, as therapists, one important thing we need to see, and I'm sure that, we have to be a little bit like detectives and think, why is this happening? Why is he being angry? Why is he being so irritable? Why is he crying so much? Why is he not eating? There could be a million reasons for that. And we need to like step back and try and figure it out. Okay, next. Okay, so we're going to talk about one of the most common problems, autism and sleep. So first, what do normally kids need? How much sleep is enough? Okay, so this is a quick table. You all can have a look at that. Okay, so toddlers need 11 to 14 hours, including naps. Preschool kids need 10 to 13 hours, including naps. Okay, and the same goes for children with autism. Next. Okay, but as we know, that there are a lot of problems in sleep. It could be problems going to sleep, problems staying asleep, frequent awakening, irregular sleep cycles. They may be awake all night and then they sleep all day. When they sleep, it may be short durations, for just half an hour and 45 minutes, or one REM cycle, which is 90 minutes, and then getting up super early, like 4 a.m. or 5 a.m. Next. So sleep problems are huge in ASD. 44% of children and 88% of adolescents have sleep problems. And sometimes these sleep problems do persist. So there are many reasons. Okay, yeah, next slide. There are many reasons for sleep issues. Okay, the first half of this slide is problems in the brain. So melatonin is the hormone which is naturally released by the brain, which regulates sleep. These hormones are released in the evening time. So they may have dysregulated melatonin synthesis, altered patterns, their clock, their circadian clock may have some uh, anomalies. And then the child may just have that decreased awareness of the social clues that habituate sleep-wake cycles. Medical causes could be different. This child could be having severe reflux, could be having seizures, it could be anxiety, depression, it could be part of the ADHD. So there are many, many reasons for sleep problems. Next. Yeah, then other medical problems could be, it could be some rashes, it could be some bites, it could be dental caries. The child could have a blocked nose. Wheezing is always worse in the night. Coughs get worse in the night, especially if it's an allergic cough. The child could be still passing urine in his bed. And some medications also affect sleep and behavior, especially if they're on some kind of anti-epileptic medication or medication for the behavioral issues. Next. So I'm sure this doesn't have to be told. Poor sleep quality and insufficient night sleep exacerbates and worsens the core ASD features. It has a negative effect on mood, on behavior, on learning. Next. And this all in turn means the parents are also not getting enough sleep, the siblings are not getting enough sleep, and this leads to a poor quality of life for the child and for the entire family. Next, yeah. So what do we do? So there are a lot of behavioral strategies for this. But maybe I will also skip this unless we want to come back and talk about it, because I know we started a little late. We can come back to these if there are questions. Okay, so I'm just going to quickly go through these. Yeah, next. Okay, so, and then, yeah, this is the slide I want to talk. So with the behavioral management and the behavioral strategies are the most important. Okay, and then along with that, sometimes we also start melatonin. But melatonin is only given to help initiate the sleep. Okay, so with melatonin, it doesn't really help in continuing the sleep because it has a very short half-life for about 90 minutes. Okay, so it's useful in addition to the behavioral strategies to help the children get to sleep. Okay, next. Okay, another important thing is the diet. Okay, so there are many, many reasons for eating and feeding problems in autism. They could have avoidant and restrictive food intake disorder. There could be sensory issues with the food. There could be oromotor difficulties, including the tone, neophobia. They don't like anything new and they want the same thing, right? So what does that lead to? Next slide. Yeah. So, for example, a child likes soft texture. Okay, so the mom just wants him to eat. So she keeps giving him the soft food. But what happens is this child has limited opportunities to learn how to chew. And then when the child grows older, it's difficult for him or her to eat what everybody's eating. And then what the soft food, the semi-solid food is continued. Okay, next. Now, when we're just giving semi-solid foods, foods that need to be mashed up, or only his preferred foods, what does that lead to? That can lead to micronutrient deficiencies. Some kids just will not eat anything except outside food and they want McDonald's and nuggets and French fries. But that will lead to a diet which is high in fat and carbohydrates. And a lot of kids have textural issues with fruits. So this leads to constipation and again, like I said, nutrient deficiencies like calcium, vitamin D, iron, B12, that is very common. And in addition to that, a lot of kids have a lot of mouthing behavior and pica. Pica is when they eat non-edible food. Like they may peel off the paint from the wall and eat that, or they may just, like to eat mud or dust, or chew metal objects, or chew paper or cloth. Okay, so that may be a sensory issue, it may be a behavioral issue, but it could also be because of iron deficiency. And this, when they do all that, they may be ingesting also pathogens, which will cause diarrhea, or they may get worms, and worms again will lead to more micronutrient deficiencies and more irritable behavior. Okay, so the restrictive pattern of food choices in children contribute to micronutrient deficiencies. They're more likely to choose carbohydrate and high fat products, which will increase the risk of being overweight. And I think again, it makes meal times very difficult and stressful, and so that affects the family functioning as well. Next. Yeah, so this restricted diet can lead to malnutrition, but on the other side, it could lead to obesity. It could cause anemia, which then again affects behavior. It could lead to vitamin D deficiency, which also affects behavior. And constipation, again, because some of the children may not be able to articulate, constipation can cause a great deal of discomfort. Vitamin B12 is very important for development. So is iron. So that's also very important for neurodevelopment. Iron deficiency is known to cause behavioral problems. So these are some things that we can actually test for and treat, and it really helps the child, okay, including deworming. Okay, next. Okay, we can skip this. This is probably useful for the therapist. Okay, so next problem is autism and epilepsy. So epilepsy just means seizures. Seizures is due to abnormal activity, electrical activity in the brain. And there is a high prevalence of epilepsy in autism. It could be anything between 4 to 46%. A lot of children who have autism, we do EEGs, and we have seen that there are abnormal EEG changes in up to 60%. Okay, but we may have EEG changes, but the child may not have seizures. Okay, these EEG changes are signs of cerebral dysfunction. Okay, so it's like a biomarker of the uh, inadequate functioning of the brain. And sometimes these abnormal electrical signals, they can interfere with the normal neural processing. So even though these abnormal changes in the EEG, which means that there's some dysfunction in the brain, even though they're not causing full-blown seizures, they do affect the normal neural processing, which means the normal learning and the normal behavior. Next. Okay, so this is what we call transient cognitive impairment. Next slide. So if you keep getting these interictal abnormalities, but it's not seizures, but they're happening many times and they're very frequent, they can have an accumulative effect where it affects cognition and learning. Okay, so sometimes when we do find abnormal EEG, even though the child is not having seizures, we do give anti-epileptic drugs because a small dose for a short time, we see if it works, may be useful to improve learning and behavior and sleep. Okay, next slide. Yeah, this is what I was saying. The interictal abnormalities, if they are happening frequently and multiple times, together the cumulative effects are significant. Next slide. So that was about just changes in the EEG, but now we're going to talk about actual seizures. Now, we said that the incidence of seizures in ASD can be anything between 4 to 46%, but there's the risk is higher if there's a lower IQ and also if there is a genetic syndrome also, like tuberous sclerosis or Down syndrome or Rett or Fragile X. Okay, so then there's a risk of seizures. Now, how do we see seizures? What do seizures look like in children with ASD? The seizures can look exactly like the features of ASD also, because they could be staring and no response. Okay, not every seizure is where the child shakes his hands and legs and becomes unconscious and passes urine and stool. No. Okay, children can have very subtle seizures. It could just be a staring episode. It could just be some blinking. It could be the stereotypies that he already has. It could be that he's not responding to his name. Okay, it could be some behavioral issues, could be disruptive sleep, could just be his eyes going to the corner. Okay, so the features do overlap with some of the ASD stereotypies and RRBs. But if it's a new onset or something different, and you know that this is really not just ASD and you have a concern, please immediately inform your pediatrician. Okay, so what we will do in that case is plan an EEG. And not just like a 30-minute EEG, it would have to be asleep and awake, especially sleep, because that's when the interictal discharges come out. And then in some cases, if we see that there's only one part of the EEG that has a change, we may do an MRI. Okay. And if we notice anything else different, like the baby has some birthmarks on his body, or his ears are a little different, or his head is a bit bigger than normal, or smaller than normal, or he's had multiple regressions, or a regression after 2 years, then we may need to do even a genetics. Okay, and usually we do a chromosomal microarray. Next. Okay, I think in your stepping stones, you must be talking about social stories. So I'm going to just skip all this again. Next. I just think social stories is a great tool to use. So I had put some up. If we have time, we can go back. I had one on traffic jams because they're so common in Bangalore. Yeah, but now what I think we should talk about is early intervention. Okay. Research and science, and not just forget research and science, parents and the kids we have seen. We've seen the difference of when we start early intervention early than later. Okay. So if, and because we talked about how the brain is developing maximum in those first 2 years, but it does continue till 5 years. It's not that nothing happens after that. It does continue. And we can rewire the brain. We don't want to change the child completely, but we can help in certain areas. And younger age at enrollment into early intervention services has been consistently associated with achieving greater gains in social communication, cognitive abilities, adaptive skills, and reduction of the ASD symptom severity. There's greater impact when starting intervention before 3 years as compared to after 5 years. But still, it doesn't mean that, okay, 5 years is over, we missed it, we didn't do anything, we've missed the bus, there's nothing we can do. No. At any point, intervention services are beneficial for children with ASD and can be started at any age as soon as ASD is suspected. Next. Yeah, so this is a nice graph showing the, like, at 1 year, okay, the earlier we start intervention, look at the lower curve. Okay, the adult ASD severity is much lower if we start um, intervention at 1 year. When it started after 5 years, okay, that's the conventional ASD outcomes. The adult ASD severity is much higher, but when you start intervention early, the symptom severity is less. Can you see the gap between those two arrows at the end? I don't have a pointer, but yeah, there is a considerable difference. Okay, next. Okay, so this is also a picture showing us the interventions given at the right time. We have more positive outcomes. Okay, so the opportunities that this child is given, the interventions that he's given, okay, how it helps in positive outcomes, because we are looking at the lifespan approach. We're not just looking at preschool or childhood, we're looking all the way till adulthood. So the things we do now sets the foundation for the for, for the child at adulthood. Okay, next. Yeah, so this is also like the societal response and services can optimize outcomes for people with autism. Okay, so um, mm, I, okay, so there is a cognitive ability on the x-axis and there's adaptive functioning on the y-axis, right? And then the dotted line is the effective feeling on opportunities. Now, if this child only gets, it's not diagnosed, low recognition, not much support, so societal adaptation is lower, that patient, the cognitive ability remains low. And even for those with high cognitive ability, they are not able to reach their maximum potential. Okay, it's still somewhere on the medium, even those with high cognitive ability. But on the other end, let's say that child was diagnosed early, received full support from the parents, from the school, from the therapy center. The ones with even low cognitive IQ, cognitive low IQ, can get much better adaptive functioning. And look at that light blue box. The majority of the children, even between medium and high IQ, can all actually reach their maximum potential. Okay, and that's what we want. Next slide. So to manage a child with ASD, that cannot be done in isolation. As a developmental pediatrician, I cannot do it alone. Okay, even the therapist cannot do it alone. this child has so many co-occurring conditions. There's so many layers to be understood. So we need a multidisciplinary team, which consists of the pediatrician, the occupational therapist, the speech and language therapist, a psychologist, a special educator, a child psychiatrist. Of course, the parent is if not bigger, the if not bigger than the rest, an important member of this team, and the social worker. In addition, we also have a next, please, a geneticist, a neurologist, and an ophthalmologist. Okay, next, next, please. Yeah, and so the parents are a key role. Okay, we never ignore the parents because the parents are the child's first teacher. The parent becomes an advocate for the child. The parent becomes a therapist and as well as a loving parent. But it is a role that is not without costs, and the implication for the family are considerable. Okay, for the siblings, for the extended family, and we're all here to just help you on the right path. Okay, so if you feel something is off, you speak to your healthcare provider, whether it's the doctor or the therapist or the psychologist. So you know your child best, trust yourself, and be confident in your abilities as a parent, because each autism child is so unique, and his behaviors, his challenges, his strengths are not at all similar to the next child. Like they say, if you've seen one kid with autism, you've just seen one kid with autism. It doesn't mean the second one is going to be anything like the kid you saw last week. So if you feel something is wrong and you need answers, you keep speaking. If something has changed, if there's a regression, if the behavior has suddenly changed, you need to speak to a healthcare provider, because there could be a co-occurring condition. A lot of times, what happens is once a child has got a diagnosis of autism, even if you go to your normal pediatrician and the child has, just started crying for something, they say, this is part of the autism. Okay, and that is something called diagnostic overshadowing. That child may be having constipation. That child may be having a severe toothache, but he's not able to express himself. That child may be actually even having epilepsy. Maybe that he's having a headache and head banging because of frontal lobe seizures. Okay, so uh, sometimes all that just gets swept under the carpet of, okay, it's part of the autism. Okay, the self-injurious behavior. Let's say a child, we had children who kept hitting their chin, and later we found it was because his ears were blocked because of a ear infection. Okay, so if you feel something has changed, something has regressed, you need to speak to a healthcare professional. Okay, and whether it is your therapist can guide you to the right person. But everything is not because of autism. These are still just regular children, will have other problems like a cough, like a cold, like a stomach pain, like a dental caries. Okay, sometimes it may be more because for sensory issues, they may not like to brush, and then they end up with very bad tooth decay that could lead to an abscess, but that child cannot express it. So it comes out either as self-injurious behavior or irritability. So we need to like look deeper. Everything is not because of the autism. Okay? So we must think what caused that change in behavior, or that child may be having a ear infection, or that child may be having a really bad rash. Okay, so we need to, those are the times when you need to take the child to the pediatrician. Oh, yes. So I think if it takes a child to raise a village to raise a child, it takes one child with autism to raise the consciousness of the whole village. Next. Yeah. So autism isn't a disease. It's a difference in the wiring of the brain. So they're just a different kind of human being. And it's very important to focus on their strengths, because that will give them confidence and that will improve their self-esteem. Okay, so it's not a puzzle. Now they say we shouldn't use the puzzle as the logo for autism. Forget the puzzle piece, because that says I'm a problem to be solved. No, think of autistics as an infinity symbol, and there are infinite possibilities of personalities, function, traits, challenges, skills, and potential. Yeah. So are there any questions? I hope I was audible. I hope it was clear. Any experiences, thoughts that anybody would like to share?
Doctor, you talked about a team of specialists to treat the
Yes.
child.
Yeah.
Yeah,
Yeah.
and almost everywhere we have taken the child to, there are maybe two or three specialties in some places,
Hmm.
um, but we don't find these together. And since there is so much on the internet and everywhere, we find ourselves a bit confused. So,
Yeah.
should there be a team leader, somebody whom we rely on for advice to assemble the team together?
Okay. I think that's a great question. There are very few places that can offer the entire comprehensive care in one building under one roof. Okay, where I work is one place like that, but the demand is way too much. We can't see every child in Bangalore, but that's where it helps to collaborate. Okay, so like I know Stepping Stone Center, they know me. So our therapists cannot manage all the children here. So we collaborate. The therapists talk to each other. The therapists speak to the pediatrician. I speak to the therapist. That needs to happen. And what we can do is who is the team who can take care of a child with autism? Because not every pediatrician can understand a child with autism. Every dentist may not want to manage a child with autism. Okay, so the important thing is if you have your therapist can be the team leader as well. Okay, but then we need to work together. When the therapist feels something is off, they can immediately contact us, or they can give you our referral, like where to meet us, and then we can see you. And then again, I can talk to your therapist because we all see different sides of that child. I'll get some information seeing the kid and speaking to you. The teacher sees something else, the therapist sees something else. So the important thing is that interdisciplinary care, that we're not in the same building, but we're not too far away because everybody has a phone. So it's working together. I don't think, I think anyone can be the team leader. I think the therapist, because they are the first contact a lot of times, they can be the team leader as well. They also need to know when to refer. And I think with today's slides, the important thing was to understand everything is not autism. Autism doesn't occur in isolation. So when to refer, when to meet a psychiatrist. Sometimes the other psychiatric morbidities are more. The child has anxiety, the child is developing features of OCD. Then you need to meet a psychiatrist. Does he need something else? So I think it's knowing who to refer to and when to refer. Does that answer your
Sure,
question?
sure, doctor, that does. Thank you.
Yeah, it's building that network of people you can trust.
Sure.
Yeah. Are there any other doubts? So there are different entry points. There are some kids who come to us directly. There's some kids we get, like some parents are picking it up super early and they're coming at 2 years. And then we assess, and then we send them out to the therapist, and then maybe see them once in 3 months and 6 months to see, are they achieving their goals? Are there new behavioral issues? What's happening? What's the progress, the goal setting and all. Sometimes we get children from the therapist, and I think that's good because there are a lot of medical and psychiatric comorbidities that need to be ruled out because this child is still a child, and it's everything. It's a holistic approach to the child. So there are different entry points, but once you're in the system, it's to create that network of a good ophthalmologist who will be able to do this kid's eye checkup, because again, most ophthalmologists will be like, no, there's a kid with ASD, I can't do it. But it's to find that pediatric ophthalmologist who can manage a child with autism, to find that dentist, to find that neurologist. So I think we can create that network. If you come to St. John's, it's definitely there, and we also collaborate with Stepping Stones. So we can work that out. It's just picking it up and doing it.
Uh, one of the questions that had come, doctor, was
Yeah.
if a child gets diagnosed with autism, how often do they need to come in for follow-ups or a reassessment?
Yeah.
Within what span of time should a reassessment be done?
So this is like an ASD reassessment, development assessment. I
Right.
think at least once a year it needs to be done, minimum. But it doesn't mean that we only see you once in a year. Okay, we'll keep assessing for the short-term goals maybe every 3 months. But yeah, and medical issues, dental issues, that has to be at least once in six. Dental maybe once a year, medical at least once in 6 months. But reassessments, I mean, an assessment takes a long time. And to see, like, these are not overnight changes. So we have to give it time. And the goal setting that's done by the therapist, we work on small baby steps. And then at the end of 1 year, we can see the considerable improvement. There will be improvement in some areas. There'll be new behavior problems in other areas, and that's okay. It's part of the journey. But I think if there are very strange behavioral changes, they're very unexplainable. Or another reason to refer would be if there's not much improvement. Okay, in a year, we've not seen that things are really going as it should, because therapists know by now, okay, these goals should be achieved in this much time. And they've seen that, wait, we're not really moved, we've just stagnated, we've just plateaued. That's also a reason we would need to look at other co occurring conditions. Yeah.
And even though we've been in this field for more than 8, 10 years, the visuals that you just showed, it's still so impactful. Like the change, the maze or the pathways of the
Yeah.
brain is like, it's still, very, it's always overwhelming to see the kind of information overload that would be happening for our kids, and how much they would be struggling to deal with it. As much as we could try to support and help them, I don't think we can completely understand the processing that would be happening inside the brain. That was a very, very impactful visual, I would say.
Oh, thank you. No, it impacted me too, especially because it was written by somebody with a lived experience, Like I'm sure many of you are parents, I mean, all are parents of children with autism, but it's still we are not on the spectrum, like the world is such a different place for them.
Mhm.
And I think that's the thing with just like because they learn to mask a lot of the high functioning. I think one thing I wanted to also say was home might be the safe space where they can just have a little winding down and downtime. So if they come home and they just want to relax for a little while and maybe stim for about 15 minutes, and maybe it's okay because they've controlled it all through school, they've controlled it all through therapy. So I think for autism parents, um, I don't know where you are all at, where you are. Like, are you parents for newly diagnosed, or are you parents of older kids? But I think it's important to know which battles to fight. Otherwise, you just burn out, and focus on the small wins and take care of yourselves, because parents of children with autism have the highest burnout. And I think anxiety levels, depression levels are also higher. So if there's a parent who's not okay, you also need to seek help out, because you're such an important person for that child. And if you're not okay, please, we're trying to break the stigma here. You've accepted your child with ASD, and part of being neurodiverse is accepting everybody and being inclusive. So parents also, please reach out for help. It's not an easy journey. I really admire and respect every single parent that comes in, because I've seen them change with time. We've seen how the parents grow from strength to
Yeah,
strength, and
yeah,
that
that's
is
very
always
true.
inspiring.
Yeah,
Yeah.
very true. Um, yeah, I think if there are more questions from the parents, we would want to reach out to you to understand, how to address those. And we can, make a list of the concerns and
Yeah,
questions that they might be coming in
yeah.
after the session as well.
And we can make a list of centers also. I mean, I'm
Yeah,
sure you have your trusted, but I could give you mine as well, who we trust because it's such a special group of children.
true.
We don't want
Right.
them to get more trauma by going to the wrong places. And
Yes, yes,
yeah.
yes, that's true. Thank you so much for joining us today. Like I said, it's been very insightful, and even though a lot of information we were already aware of, the way you
Yeah.
put it across and the way you simplified it, it was amazing. Thank you so much for this.
Thank you,
Thank you,
ma'am.
Purnima. Thank you, Vijay. I'm so
Yeah.
sorry about the confusion at the beginning. I know
No,
we
no
wasted so much
worries.
No
time.
worries.
No worries. Like Purnima said, it was just so helpful, even clarifying all our basic medical concepts as well. Just the difference between, genetics and hereditary and congenital aspects, because that at least, when parents are asked for genetic testing, there's always that question, why am I being asked? Am I responsible? So, just, clarifying all those aspects for the parents also is very helpful as part of psychoeducating them as
Yeah.
well.
And I think a lot of parents blame themselves. So that's another reason for that. It's not anything that you did, it's nothing you ate.
Mhm. Right.
Okay, they'll say because we ate this and my mother-in-law said I did this. And, it's not because of all that. And another thing parents also blame themselves is, I mean, because that regression happens around that 18 to 24 months. And sometimes the parents are giving screen time. Screen time doesn't cause ASD, but it does worsen it, right? So I think also that, like, I think parents have enough guilt thinking that they are responsible for all this, but no, it's not because of you all, okay? It's not because you showed them the screen. Of course, now you should stop, but
Yes.
this is, these are things that are beyond us, actually. Yeah.
Yeah.
Mm.
Thank you very much, ma'am.
Yeah. Thank you. Are there any other questions?
If there are any
Um,
questions, parents, please. Yes, go ahead.
Actually, I have a doubt.
Yeah.
So, I have a client who is like 2.9 right now, and he actually have sleep disturbances. Like he maximum get 4 hours at sleep at night,
Oh. Mm.
and morning like he sleeps like 1 hour 30 minutes, like when he goes to the daycare. So is
Mm.
there any activities which actually helps with the sleep issues, or like is there anything that you can suggest
So
to have with sleep?
that is very little sleep that he's getting.
Yeah.
Okay, so and no, we really need to look into that because he's very young and such little sleep is gonna make issues worse. Like they say, sleep begets sleep. So you sleep well and you continue to sleep well, like
Yeah.
but this is like you said, 4 hours in the night and how long in the day?
In the day, like 1 hour 30 minutes max
Yeah, so
when he
that's just
goes
like
to the daycare.
5.5 hours, which is half the requirement. So I think we need to,
Mm-hmm.
there are no activities. We need to look into why he's doing that. Again, it's like, why is he not sleeping?
Mm-hmm. Yeah.
So I think rather than activities right now, maybe he can meet a pediatrician or meet his therapist who can figure out his routine and what is causing that. And then we change that.
Yeah.
Okay, so he should
Yeah.
probably come in to meet somebody. Yeah.
Yeah. Thank you.
Welcome.
So, parents, if you have any further questions for Dr. Nelia, please reach out to us. We'll try and get it answered and clarified as soon as possible. So, we are ending our session today. Thank you so much again, Dr. Nelia. We had a wonderful time and a lot of insights about autism and what kind of medical support we should ask for or we should refer to when
Yeah.
when the parents come with these kind of concerns and questions. Thank you so much.
Welcome.
So, team, our next parent support group will be on May 3rd, and we will have Miss Priya Buran, who's an occupational therapist. She will be taking a session on sensory integration. So please join us next month. Thank you so much. It was wonderful having all of you here.
Bye.
Bye bye.